just before we get started with our next presentation, we're just going to see one more of our patient stories, which links us in nicely to this afternoon's topics around sort of white cell disorders. So this is going to be Mike. His story is all about... Mike's story is all about his diagnosis with chronic myeloid leukemia. So, got the right way through. Just go back to... there we are, it's this one. Okay, so we'll just play Mike's video and his story as one of our cancer patients.
I was diagnosed with leukemia in 2017, late 2017. I had been experiencing bruising, which I couldn't attribute to just wear and tear or bumping into things, and decided that these spontaneous bruises needed following up. So I contacted my doctor and explained over the phone what was happening, and they said, right, come in and get a blood test, which I did. And within 24 hours, I had a call to say, we've made you an appointment at the hospital. Never a good sign. And so when we moved into early 2018, following blood tests, and subsequently a bone marrow test, I was advised that I had CML, chronic myeloid leukemia. It was a bit of a shock because I had been diagnosed in 2007 with prostate cancer and coped with that okay. But leukemia, the word leukemia is pretty scary. And I couldn't really get my head around that, to be honest with you. Since diagnosis, I was put on, I can't remember the name of the drug, but a chemical which brought my white cell count under control. That took a few months, was a little bit brutal, but once things were under control, I was then put on a TKI treatment called imatinib, which is a daily chemotherapy, and I've been on that ever since, and I've responded really well. I'm now technically in remission and could consider going on to treatment-free remission, although I'm not sure whether I'm going to do that because I was 76 when I was diagnosed and I'm nearly 82 now. So, you think, well, if it's working, let's keep going with it. But I have to collect the tablets from the hospital. Can't get those through my GP. And that entails a 28-mile round trip to Stepping Hill. And initially I'd got some difficulties with getting the medication. I had to go on a monthly basis to collect meds, even though I was only getting my blood tests done every quarter. I had a bit of a fight on that, and it's good to know what best practice is, and what I was being offered was certainly not that. Being given a leukemia diagnosis is scary. It's slightly overwhelming, and I didn't understand. There's lots of terms in there which you can't get your head around. Unlike prostate cancer, where it's all about plumbing and you think you understand it, leukemia is a pretty scary word, particularly when it's used in conjunction with yourself. So I have had good care from the hospital, regular visits, blood tests, just to make sure things are on track. I've got a good relationship with my consultant and with my CNS. And I certainly think that is an absolutely key to anybody that has a diagnosis. I realise that I'm lucky in that my cancer is entirely treatable, whereas others in the haematology spectrum may not be so fortunate and may have to go through much more grueling treatments than me. So, but in terms of the support that you should expect, I think that consultants need to be clear, friendly, supportive, and explain the treatment options that they're offering. I think it's important that the patient get to know their CNS so that they can talk to them regularly. And I think it's also important that the patient be signposted to support networks or charities where talking to your peers can be of great assistance to the patient in understanding their condition and have coping strategies by discussing that with people who know what you're going through. From a primary care point of view, I worry that the current system is a bit too binary in that you go to your GP initially for first diagnostics, but then you'll refer to the hospital. And after that, there's a tendency for the GP practice to think, well, you're under the care of the hospital, that's us done. But people are still people. They still get other things, and they need being looked after in a holistic fashion. You get lonely, you get scared, and having somebody in your corner, like your GP practice, is really important. So regular follow-up is good. The GP should understand the background of the patient, whether they've got a support network available, whether they've got people they can talk to. But they're staying in touch with the patient on a regular basis is one of the most valuable things which can be offered to a patient, knowing that there's a network out there, not just the usual routine of going to the hospital and getting that treatment that they need. So don't abandon them just because they've been diagnosed with cancer. They're still people, they still need your help, and I hope that this will be of assistance in reminding you, like I say, we're still people at the end of the day with all the other issues that confront us rather than just cancer.
Right, so that was Mike's story, who's one of our patients with chronic myeloid leukemia. So I'm going to hand over now to Dr. Say, who's one of our consultants over at Stepping Hill Hospital. He's going to talk about chronic leukemias in general.
Thank you very much. Yeah, I'm Dr. Sai Chirputkar. I'm one of the hematologists at Stepping Hill. He's not my patient, but I think he's done such a nice job of the presentation here. It's almost like I don't need to do this. He's covered all the important bits. But I've made this presentation, so I'm going to present it. Here we go. The chronic leukemias. Hematology is one of those specialties that's kind of pushed under the carpet a little bit because it's quite a small specialty, a niche specialty. But how often do you see abnormal blood tests? All the time. And more commonly, you will see the chronic leukemias. Hence, let's just go through these. I do agree that it's going to be a short presentation. I hope a simple presentation. So the first patient that I'm presenting here is a 65-year-old gentleman. He's had routine blood tests with his primary care physicians and was found to have a normal hemoglobin, slightly high platelet count, and a high white cell count. The next thing we'll look at, anybody? When you've got a high white count. Yes, differential, and then the blood film. So the differential, it showed mostly they are neutrophils. There were some eosinophils, some basophils, and just very occasional blasts. So clearly, if there are too many blasts, that's the acute leukemia. You've had that presentation. Obviously, it's not going to be that. It's mostly mature neutrophils, hence a chronic leukemia. That's the blood film we look at. And to point out, it's not just, so these are the neutrophils, which are the mature neutrophils. There are some which are, so it's called a left-shifted film, which means we get the more immature forms in the peripheral blood. You get your myelocytes and metamyelocytes and band forms. Now, I'm just throwing words around, but bear in mind that it is quite a left-shifted film. You see some eosinophils and some basophils, and occasionally some blasts. So this is a chronic myeloid leukemia, which is a clonal disorder, usually peaks around 60 to 75 years, and unfortunately more common in men. Hemoglobin and platelets can can be normal. You can get low hemoglobin, low platelets, sometimes high platelets. Now, most commonly, you would pick this up in what is called the chronic phase, which is exactly what we described. But there are two other phases to it. The accelerated phase, where it's kind of moving towards becoming a leukemia, which is the blast crisis. We've talked about this. When there are less than 10% blasts in the peripheral blood, that's when we call it a chronic phase, CML. This is a fairly straightforward one to diagnose for us anyway, looking at the blood film, but also because they have what is called the Philadelphia chromosome or the BCR-able translocation, which you can pick up. And then that's a home run. So usually, people are often asymptomatic, and you pick it up purely because it's much more common now to do routine blood tests. You would often pick it up as in asymptomatic people. But if people do get symptoms, it's because of the splenomegaly. So you can have malaise, fatigue, early satiety because of splenomegaly, or pain in the left hypochondrium, again, because of that. Rarely, because the count becomes very high, people may present with hyperviscosity symptoms of just not being able to concentrate, blurred vision, retinal bleeds sometimes, headaches, shortness of breath, that sort of thing. Now, how urgently do we need to treat it? It's usually within days to weeks, not weeks, I would say a week or two. That depends on the count. We would previously use something called leukapheresis, where if the white count is very high, you just take the white cells out of the system. That was often used if you had hyperviscosity. No longer used because we have something magic called TKIs, or tyrosine kinase inhibitors. Sometimes we use this hydroxycarbamide just to bring the count down, especially if you're waiting on a BCR-able result. I'm sure you have all come across patients on tyrosine kinase inhibitors. Yeah. So this is what has changed the scene for CML from sort of overall survival of 5 years, 3 to 5 years, to probably not reached. So these tyrosine kinase inhibitors, there are few generations, you don't need to know, but all the inhibs are all the tyrosine kinase inhibitors. Now, what can often be seen in primary care is the issues you get with tyrosine kinase inhibitors. I've split them into two because those ones, really, we should be monitoring them. And it often happens that that's where they come. However, there is an increased cardiovascular risk with most tyrosine kinase inhibitors. Hence, it is important to have this partnership with our primary care colleagues. For managing blood pressure, sugars, advice about optimum weight. There can be problems with fluid retention, and that can often be presenting. They can often come to primary care for that. So this is the important bit for us. How do we work in partnership? Usually, diagnosis is not something you need to refer to hematologists because this is picked up on a blood count. You'd get a blood film done reflexly by the lab, and we'd pick it up. But ongoing lifestyle management for cardiovascular risk, that is something which our primary care colleagues will definitely be helpful with. Do they all need COVID vaccination? It's not a very myelosuppressive condition. It's not something that causes a lot of immune suppression. However, the reasonable advice would be, yes, they should all go for COVID vaccinations. And we don't stop the TKIs if they do get COVID. That's CML. Anybody have any questions? Or shall we crack on? Move on. So this patient is a much older one, 79-year-old. He's come in with feeling tired and short of breath to primary care. He's got some bruising. He's also on aspirin. There's no bleeding. And then you've done his bloods, which show hemoglobin of 88. This time he's got macrocytosis, which means the cells are quite big. The white count is raised, 33, not quite as much as the other guy, and platelet count of 55, so that's low. Low platelets, high white count, and low hemoglobin with a macrocytosis. So again, the next thing we do is, well, the differential. Neutrophilia, majority. There are some monocytes, quite a lot of monocytes, so you know where I'm going with this one. No? An occasional blast. And the blood film. So that shows a lot of these monocytes, and there are some neutrophils which look quite abnormal or dysplastic in that they don't have the nice granulation, they don't have the nice segmentation. So funny looking neutrophils and lots of monocytes. So what we have is a CMML, or chronic myelomonocytic leukemia. Now that's just an additional M as compared to CML, but the diseases are completely different, and the way they behave are very different. The prognosis is very different. So this is really a dysplastic syndrome. You've all got patients with myelodysplasia or MDS. This is very similar to that. It's just on that spectrum, except you get lots of monocytes along with it. So you have dysplasia and proliferation. You have cytopenias, and then the risk for progressing to acute leukemias. The difference from MDS is a lot of people with CMML can have hepato or splenomegaly, and you can often get lots of effusions everywhere, pleural, pericardial, peritoneal effusions. Skin rashes and lymphadenopathy. So that's slightly different from most myelodysplasias. Unfortunately, the treatment is very similar. So CMMLs are usually non-urgent referrals. Often, so I've presented somebody who's quite progressed in their CMML, but often what you'd see is a monocytosis of, say, maybe 3, 4. Rest of the blood count looks completely normal. Those patients don't need very urgent referrals. If there are no cytopenias, my advice is usually don't refer. You can monitor them 6 months to 1 year, and if there are cytopenias, then we're happy to see them. 2-week wait referrals are very rarely needed for CMML, unless there is profound anemia, neutropenia, or hepatosplenomegaly effusions. So if the patient is unwell, and if you're in doubt, by all means, happy to accept 2-week waits. COVID boosters for these patients, again, the sensible advice would be absolutely give it, because it's quite a dysplastic picture. Not everybody gets lots of infections, but it's simple enough to go ahead with. I think that's it on CMML. Anything? Any questions? We're just cracking through. Excellent. And this is the last patient you'd be pleased to know, 68-year-old, who's again had routine bloods, normal hemoglobin, normal platelet count, and a slightly high white count. The differential here shows predominantly lymphocytes, so we know we are heading towards the last one, CLL. They've got, so what happens often in the lab is if you find somebody with a very high lymphocyte count, the lab would reflexly send bloods away for cell markers. The gray area is when the lymphocyte count is raised, chronically raised, but less than, say, 10 to 12, which is very early stages. My general advice to our lab certainly is that if it's less than 10, if the lymphocyte count is less than 10, and patients are asymptomatic, we don't do the cell markers, and I'll come to why that is. But you would reflexly send for cell markers, and the things to watch out for are what are called B symptoms. You've had your lymphoma thing, isn't it? So we all know unexplained weight loss, night sweats, fevers. Those are the things to watch out for in terms of B symptoms. And examine for lymphadenopathy or organomegaly. Now, if there is lymphadenopathy or organomegaly, or if there are any of the B symptoms, by all means refer as a 2-week wait. But the majority of patients you would get would not have any of those, just a lymphocytosis. Often, the cell markers would have been reflexly done by the lab, and it is also possible that you just get the results for the cell markers saying, this is CLL. And then it's a tricky one, because CLL, as a general thing, it's quite a slow-growing cancer, and it's not something that needs treatment urgently. But still, in your surgery, you'd see somebody who comes in with a diagnosis of a cancer, and it's very difficult to say, we're referring you, but routinely, to hematology. I mean, most of the times, we are very happy to accept advice and guidance, and we can give advice on whether somebody needs a 2-week wait referral. If patients are anxious, and I know this is very easy for me to say, don't refer it as a 2-week wait, but if people are very anxious and need that reassurance, then okay, go ahead with 2-week wait referrals. My usually, okay, this is just how we diagnose CLL. They are very specific morphology and cell markers. As we say, lab can sometimes send for cell markers. And that's the film. These are all mature, small mature lymphocytes in the peripheral blood. Other issues that happen with CLL is anemia, which can be because of the CLL itself, but all CLLs go with a lot of immune problems, including autoimmune hemolysis, hence the anemia, or another immune problem called pure red cell aplasia can happen. The low platelets because of CLL or because of ITP, again, it's an immune-mediated problem, which happens more frequently in CLL. You can get low neutrophils. Sometimes this is usually with post-treatment CLLs that you get a low immunoglobulin level, IgG level, and a secondary hypogammaglobulinemia. We don't need to go into this, other than the fact that Binet stage A, which is just lymphocytosis and less than 3 areas of lymphoid enlargement with no B symptoms, that's the subset of patients that often are referred back to primary care for monitoring. The other Binet stages we usually tend to keep hold of. So when do we treat? That is the key for sort of sharing care. People with B symptoms or cytopenias, we definitely need to start treatment. If the lymphadenopathy is causing or is imminently going to cause pressure on any vital organs, then we start treatment. And if the doubling time is very rapid, then that's usually an indication people will have symptoms very soon. So those are people we would treat. Now, we've covered that briefly on 2-week wait referrals. If you've got any other comments to make on CLLs and 2-week wait referrals, please do come out with that. Majority of our patients are on active surveillance, what's called watch and wait. So there will be Binet stage A, which I'll come to, which we often refer back. The important bit which can sometimes get forgotten is that CLL patients are at very high risk for infection. Should be a low threshold for starting antibiotics. So whichever Binet stage A, B, or C, they are high risk for infection. From your end, if they do present with any start antibiotics. They should be for flu vaccination and COVID vaccines. So there used to be these CCGs which have been dissolved and reconstituted into something different. The Stockport CCG, we used to have a shared care pathway on that, and what was the handheld leaflet for CLLs. So as I said, Binet stage A's, we would refer back for primary care. Some Binet stage B as well. We would see them initially every 4 months for the first year and then 6 monthly for the second year. If everything remained stable, they'd get this handheld leaflet which had information about CLL and also, so what is CLL? What was their baseline investigations? What were the lymphadenopathy? So they know what it is. And also some guidelines for our GP colleagues for when to refer back and how often to monitor, which was 6 monthly for the second year and once a year thereafter if everything remained stable. And then recommendations for when to refer to hematology, which was if they had an anemia, if platelets dropped below 100, lymphocytes were at least 30 and doubling within 12 months, or they had rapidly enlarging bulky lymph nodes, B symptoms, refer back as pro forma. But that's now gone somewhere in the ether. But we do send patients, if we are discharging back to GP care, then I do send the handheld leaflet with them. Anybody from Stockport? No. So yeah, they can bring that in for each of their appointments. So that was a brief overview. I hope that was at least of some use to people. Any questions? No? Wonderful. Thank you so much.
Thank you, Say. So one of the things we're looking at is going to be standardising things across Greater Manchester now. So obviously previously we had the CCGs and each locality had its own shared care protocols or guidelines. Some CCGs accepted patients back on shared care protocols, some didn't. So we still have these historical differences across Greater Manchester that we are slowly but surely trying to work through to iron out. So hopefully we'll be doing things as one Greater Manchester in the future. Lovely. I'll talk a little bit at the end when we wrap up around referrals for sort of slightly abnormal blood counts and things, and we'll bring everything together to close. So we'll move on in the interests of time. So our next speaker is Dr. Barnes, who's from the Northern Caroline Salford site.
Okay, I will try and not dwell on things too much in the interest of getting to the end of time. Oh, sorry, wrong way. Okay, so I always put, obviously we're concentrating on lymphoma, and this was in the context of looking at white cell disorders in general, and sometimes I think still useful to set the scene. I'm not going to go over what a cancer is, because you all know that, but in terms of haematology, it's always useful to think about liquids and solids, and you've had, I think, all the acute leukemias, the chronic leukemias now, so obviously we're mainly in the solid phase. And then in those solid cancers or hematological white cell cancers, then things can grow quickly, like acute leukemias do for the liquids, which are high grade, and things can grow slowly, like CLL, and they'd be your low grade. And then remember in lymphoma, that's our little malignant cell lymphocyte. So we've got malignant lymphocytes accumulating lymph nodes, and so predominantly the patients you're referring to us have got lymphadenopathy, although not always. They occasionally spill over into the blood. But that's usually obvious, a bit like the acute leukemias, in that you'll have a pancytopenic patient, and often they're one of those, like the CMLs, where we're the ones chasing you rather than you trying to chase us. And that's more rare. They occasionally infiltrate other organs outside the lymphatic system, but the kind of key message with lymphoma is it's all about getting a biopsy. So we can't make a diagnosis without a biopsy. We often get people referred to our MDT, particularly after CT scans with lymphadenopathy, thinking that the MDT can somehow make a diagnosis. We can't, and that's why it's sometimes in this infuriating situation where we say, well, send them, get a sample and send them back. We don't do biopsies. And the best person to sort of talk about making what to biopsy is often the person who's done the scan or the person who's going to do a biopsy, particularly if it's radiology. But when we talk about referral, it's you sort of think about where the lymph node is to think about where you're going to send it. So I've got a case that we'll talk to, but this is why we harp on about this, is because lymphoma is this mismatch of lots of different conditions with amazingly different treatments, from watch and wait like we do with CLLs and the low-grade non-Hodgkin's lymphomas to aggressive inpatient chemotherapy like with a Burkitt. So we have to have a diagnosis, and the best person to talk to the patient is the person, whoever's arranged that CT scan, if that's where this is coming from, or who's seen that patient and they've got a lump. It's about thinking where you refer that patient in. So we won't dwell on this. Spleen's just one big lymph node. I was going to do something about isolated splenomegaly, since that's another one of the lymphomas we get. And then the only reason for putting this up is just because chronic lymphocytic leukemia is very much like a low-grade lymphoma. And just as with CLL, they're otherwise very well, it's often incidental finding is that we just watch and wait, and these things don't change quickly. So I've got two cases where the GP was the best, most efficient person in the pathway, but it's very much, this is our experience with lymphoma, is that a lot of our patients come actually from other sources rather than the GP 2-week wait referral. So this is the first case. We've got a 59-year-old woman. The fact that she was the wife of a solicitor and the mother of 2 doctors did her no good at all in getting quickly through her pathway. which just goes to show that even a really well, and she was very well educated, well informed, lots of people kind of pushing her pathway on, is that she still took a remarkably long time to get to diagnosis. So she'd come back from holiday, had noticed a bit of a lump on her chest, and she just started doing Indian head massage and thought it was all just that she'd done something differently, got a bit of a strain, maybe pulled a muscle. Eventually went to see a GP in December who, as soon as they saw her, just referred her to breast. Okay, so lump on the chest or an axilla, breast, have a one-stop clinic, or in most, obviously, is a little bit different. And this is, again, one of the reasons her pathway fell slightly is that breast is all centralised. There isn't breast at Salford, so this lady was referred to Wythenshawe. So she went, had a mammogram and an ultrasound within 2 weeks, which is pretty good for Christmas and New Year. But had an awful experience, basically because she wasn't a breast cancer. So she had this awful experience of an ultrasound where they said, oh, this is very abnormal, this is very strange. You've got a big mass eroding your rib. This doesn't look like breast cancer. She had a couple of abnormal lymph nodes as well. But unfortunately, because of some of the features on the ultrasound, although they did consider lymphoma, they referred her down a sarcoma pathway. And sarcoma tends to take quite a long time. They are very MDT driven. Everything goes to MDT before a biopsy. And she had a CT very quickly, had lots of lymph nodes. That one was possibly more indicative of lymphoma than sarcoma. But she was on that pathway. So it then took until the 1st of March to get a biopsy. So the main reason for saying, for sort of bringing it up to weight, is you know who you're sending to us in terms of lymph node enlargement. I think there's always these kind of nebulous people with sweats. I've never seen a lymphoma present with just sweats. There's always something else going on. Sweats we tend to divert to the Rapid Diagnostic Centre these days. But if they've got a lump, then and it's persistent and it's not obviously related to a local infection, it's been there a while, or it's very worrying, then just when you're thinking about referral, think about who will do a biopsy the quickest. So one-stop ENT clinics are really good. The one-stop breast clinics, by and large, are really good. If it's not the neck and it's not a breast or axillary lump, then yeah, send it to us and we'll scan them and then get a radiology to do a biopsy. So, symptoms of lymphoma in general, lumps and bumps. You can get sort of GI, very occasionally get these GI involvements. When we were talking about CLL night sweats, so they've got to be drenching. Everybody above a certain age has got a few sweats. So they really have to be drenching, wetting the bed through, having to put towels down at night. Weight loss has to be more than 10% in the last 6 months. And unexplained fever. And it's the unexplained bit that's really important. I've seen at least one TB that was referred as query lymphoma. So we said pancytopenia is less common, and itching and fatigue. These things are usually late signs. So our lady who I will tell you had Hodgkin's, and we'll come on to Hodgkin's in a minute, if you think back, she first noticed that lump in October. She wasn't seen, so when she eventually had a biopsy on the 1st of March, she had a result about the 9th of March. That was all at Stepping Hill at Wythenshawe. So the haematologist there said, oh yeah, but she doesn't live here, and referred her to Salford. But did request the PET scan, and we saw her and started a chemo a week later. But a very long pathway, so 6 months, and by the time I saw her, she'd certainly lost weight. She had itching, which is you see something, again, a bit like sweats on their own. Itching on its own is generally going to turn out to be something else, but she had quite horrible intractable itching by the time she was eventually diagnosed. So bloods from a GP point of view, honestly, just a blood count. And LDH is really useful. It's a marker of turnover of disease. If you had someone with a very high LDH and this sort of history, you'd be pretty worried that you'd need to be doing something more urgently. We always do virology by the time we get to us, but obviously HIV is really important in this sort of population. We hardly ever do bone marrows anymore, so every now and again we get referred, for someone with a bone marrow. Because of PET-CT, which is very good at picking up activity in the bone marrow, we almost never do bone marrows anymore for staging, but obviously biopsy. And then in terms of staging, I think, you're not staging someone. The important thing for you is that patients come and they're, because all the other cancers are so much more common, breast and bowel, is that if you tell someone they've got stage 4 cancer from a lymphoma point of view, that sounds really bad. Whereas from our point of view, what we're always explaining to people, this is circulation. It's often lots of nodes involved at diagnosis. Hodgkin's is different, and we'll come on to that, because it's got something called contiguous spread. So it spreads from one lymph node group to the next. So it's much more indicative when you've got stage 4 disease, of advanced disease, whereas non-Hodgkin's lymphoma is a lot more patchy. So we now do PET scans, which are very, very good. One, it's showing you where all the disease is at the beginning, and 2, making sure you've got rid of it. So we said liquids and solids, high grade and low grade, and then that first breakup from us is Hodgkin's or non-Hodgkin's. And this lady had Hodgkin's. So Hodgkin's is a high grade, it grows quickly. So this was a long time for her from her first symptom to diagnosis, and she had quite advanced disease when we got there. So important because of that peak in young adults. So when you're seeing a 20-year-old with a lymph node, then this would be something you'd be thinking about in the back of your mind. Rare in children, we said that contiguous spread, and it's often neck nodes, so ENT is often where we'd sort of direct things to go first, because they do the biopsies to give us the answer. Axillary and then inguinal. And then we said constitutional symptoms are really late. So pathological diagnosis, we always like films and haematology, and that's that little owl eye cell, the Reed-Sternberg cell. And I wouldn't dwell on the different types, but the prognosis is really good. And to the point where, a bit like with childhood ALL, there's a lot of, it's not just about getting rid of the disease, it's about keeping people well once they're cured of their disease, and looking at long-term side effects. So when I first started training, we were using ABVD, we're still using ABVD. But what we try and do now is to PET scan early so we can get rid of the bleomycin, which is horrible for your lungs. Okay. So case number 2, again, the GP was definitely the best point of contact in this case. So he had a groin lump. The GP did an ultrasound scan and referred to the surgeons. Did go on a sarcoma pathway, but actually he was seen by a general surgeon at Salford. And this is another reason that you can sometimes get massive delays that aren't any of your fault, is that the patient went away for 3 weeks. But had what looked like pretty localised disease anyway on CT, did get an excision biopsy, and started chemo. So he had non-Hodgkin's lymphoma, which was predominantly limited to his groin, even when he presented. So most of them are B cells. Remember we talked about the cells that as the pathology is what the cell is that's abnormal. They've got a much more irregular pattern of spread in comparison to Hodgkin's lymphoma, but a massive increased incidence over the last 50 years, and particularly in a Western population. So very much like Hodgkin's, superficial lymphadenopathy, but far less frequently constitutional symptoms. Other sites of disease, anywhere we've got a bit of lymphoid tissue that is going to defend us against infection, so the GI tract and sometimes the lungs in that mucosa-associated lymphoid tissue. Abdominal disease, not infrequent. And then always, anything that's less common is usually bad. Most things are B cells. When it is T cell, they're one of the ones that have quite a lot of skin involvement. So high grade or low grade. So most of what we see, we said Hodgkin's lymphoma is about 1/5, and then of the rest of it, the majority of what we see is either low grade, which is follicular lymphoma. If you're sticking CLL in this group, then that's probably one of the commonest ones we see. So grow really slowly, often have gut marrow involvement, but not to the extent where they've got cytopenias, and often just need to be watched. Just like with CLL, there's always the potential if something's growing slowly that it could grow quickly. So there's always a potential to transform. And then that was just to show you the breakup again. There's follicular, and that big one at the bottom is diffuse large B-cell lymphoma. So the majority of high-grade lymphoma that we see is diffuse large B-cell lymphoma. So usually comes on really quickly, usually rapidly growing lymph node, and need treatment quickly, but a very good chance of curing. So we always use steroids in combination with chemotherapy, and a bit like ABVD hasn't really changed. Until very recently, we were still just giving something called R-CHOP to everybody, but there are now more antibodies. So rituximab's been around for quite a bit now, and it's always that quest for looking for a targeted therapy. Rituximab's against a B-cell marker CD20. We've now got something called obinutuzumab, which this is derived from mice. Obinutuzumab is a humanized monoclonal antibody, and then polatuzumab, which is against a different antibody, 79B. So things have changed, and it's the antibodies that have changed. So we won't, wrong way again. So we won't dwell on T-cell lymphomas, except to say that anything that's less common is usually worse. And they behave much more like acute lymphocytic leukemia and tend, certainly from where we are, go to the Christie. So I suppose that one thing just to follow on from the CLL is about discharge and about that. So the high-grade lymphomas, because they're cured, are often discharged back to GPs, particularly post in the era of COVID, after 2 or 3 years of follow-up. The low-grade lymphomas we tend to keep, but there may be more on, a bit like the handheld leaflets, what we're going to call, or we call patient-directed follow-up. But they generally stay under us. And I will leave it there. You're welcome. Did quite well.
You did very well, thank you. Okay, so that finishes sort of the presentation section of today. So I was just here really to do a little bit of rounding up at the end of the day and let everyone know what's coming up for the haematology pathway over the next year or two, really. So one of the things that we're working on very much is standardising care across Greater Manchester now. So avoiding this difference in localities and referral patterns and what will or won't be accepted and what is and isn't discharged back to primary care. So we're looking now at things like clinical decision support tools and embedding those in the primary care electronic systems. That's something we're actively working on now with the early and fast diagnosis teams. We're also looking at personalised care for our patients. So again, who we're discharging back to primary care when it's appropriate to do so, what information we're giving them, and what the mechanisms are for following those back up in secondary care, working very closely with aftercare coordinators in this. So there's a few things coming up for the future. Very much, if there's anything our primary care colleagues would like to be involved with or would like us to be looking at, please let us know. We can be contacted through the Greater Manchester Cancer website via either Pathway Manager or myself. Let us know what you're thinking about things. So if you want us to, we're working on the decision support tools at the moment. If there's any comments you want to make around that, things you'd find helpful or also unhelpful. We're looking at things like thresholds for referring patients in with abnormal blood counts. So people who are asymptomatic, who have a slightly raised lymphocyte count, at what level do you want to refer them in? You can always use advice and guidance. That's what it's there for. Ask us and we'll tell you whether we think we need to see them. But trying to standardise it. So having one consultant who wants to see absolutely everything, so a lymphocyte count of 3.8 being referred in, versus somebody else who's saying, no, I only see patients with a lymphocyte count higher than 10 or 15 or 20. Trying to get things a little bit more standardised. The same with the neutrophilias. A neutrophil count of 7.5 is very unlikely to be anything hematological.